We're going to be talking about vital signs today for your Foundations of Nursing course. So throughout this lecture, we will be talking about the physiology and expected reference ranges of the vital signs. We're going to talk about assessment techniques used to obtain vital signs and how to analyze any alterations in the vital signs. We're also going to discuss how to plan nursing interventions in response to any alteration in the vital signs. And then lastly, we're going to learn how to evaluate the effectiveness of the interventions to determine the extent to which the client outcomes have been met. So what are vital signs? So most commonly, they're known as blood pressure, pulse, temperature, respirations, and oxygen saturation. However, pain is usually considered a vital sign as well, and it is often assessed at the same time. Vital signs are obtained because it can have a big impact on how a person's vital signs are. So vital signs are a direct reflection of the body's essential functions and provide important information about a client's health status. It can show us the effectiveness of the circulatory system, respiratory system, their neurological system, and the endocrine system. So this can tell us if any of these systems are maybe not functioning properly. And then, as I said, patient's pain often influences their vital signs, so it should always be included in the vital sign assessment. So information about vital signs is objective data. So you have your subjective data, which comes from your subject or your patient. And then you have your objective data, which this is something that you observe. So this comes from something that you see or hear, anything that you experience with your senses. Okay? And so why do we take vital signs? So this serves as a baseline data. So when a patient is admitted to the hospital, we always get vital signs first to get their baseline. Now, they may have something going on and this is not their usual baseline, but at least we have something to go off of. So that way we notice any changes, we compare them to the baseline to know if it's significant for this patient or not. It helps us identify trends or any consistent patterns that indicate a change in a client's condition. So for instance, you will learn about orthostatic hypotension. This just means when a person stands up or changes position, their blood pressure will drop. So they'll have a pretty significant difference in blood pressure from when they're lying or sitting to when they're standing. So you can do this by taking their blood pressure when they're lying or sitting and then when they're standing. And that helps us notice if they do have the orthostatic hypotension. It shows us a pattern. When they stand up, their blood pressure drops. This can also go with oxygen saturation. If somebody is coughing or their oxygen saturation may go down, or maybe when they walk, any kind of exertion, you may find a trend that their O2 saturation is decreasing. And then vital signs guide treatment decisions and nursing interventions. So if our patient has a high temperature, we're going to consider probably giving them Tylenol or something to help lower their temperature. Or maybe they have 45 blankets on them, so we're going to remove some of those blankets to try to get their temperature down, depending on how high it is. Okay, and it's used to evaluate the outcomes too. If you've done an intervention, maybe to lower blood pressure or to treat pain, and then we go back and check, the patient says their pain is better, and therefore their blood pressure is better. A lot of times with pain, you'll have increased blood pressure, could have increased respirations as well. So we can use that to evaluate if our interventions are effective. Okay, so we discussed that vital signs should be done on admission. And then usually they have orders that are put in by the doctor for how often the vital signs should be checked on a patient. Now, this is done based on the patient's acuity or, how stable or unstable they are, and just based on why they're in the hospital in general. So sometimes you'll have every 4 hours, every 6 hours, every shift, etc. If they're in the ICU, it'll probably be at least every 1 hour. Sometimes it'll be every 15 minutes. So you just go by your hospital's protocol there as far as how they are ordered. So that means every 4 hours you're going to be getting your vital signs no matter what. This does not mean that this is the only time you're going to get their vital signs. Because if you suspect or observe a change in the patient, then you are going to get vital signs then as well and evaluate what they are and if we can figure out what's causing the change. Also, if you give certain medications, you want to make sure to check vital signs. So any blood pressure medications, you want to check before and after you give them. Pain medications can also lower blood pressure. Maybe the patient was having trouble breathing. They got a breathing treatment, such as albuterol. So then we're going to assess that after that intervention to see if that helped the patient breathe better. Maybe it slowed down their respirations, increased their oxygen saturation. Another thing with albuterol is it can cause an increased heart rate. So you want to monitor that as well. So just make sure, when you get to clinical, you're looking at medications, make sure to look and see what vital signs you need to monitor in order to either make sure the medication is effective or the patient's not having an adverse reaction to the medication. And then post-surgery procedure, we're always going to check their vital signs after that. Usually those are per hospital policy, but a lot of times they're every 15 for an hour, and then every 30 minutes, and then every hour, every 4 hours is kind of how it usually progresses, but that'll kind of just depend on your hospital policy. So some changes that you might notice is a loss of consciousness or maybe just a change in the level of consciousness. That would alert us that something is not right. We need to check their vital signs and see if maybe their blood pressure is too low, maybe they're not oxygenating well, maybe their heart's gone into a funky rhythm and, they're not being able to perfuse their body like they should. And then you always just want to make sure that you're adhering to the correct technique, because if you're doing something incorrectly, this can cause a false result. And so we may treat something that doesn't need to be treated, and then that could cause more problems. If my patient's blood pressure seems to be high and I give them, a medication to lower that blood pressure, then come to find out, actually my cuff was just way too tight, their blood pressure was normal, well now they have low blood pressure. So it's really imperative that you make sure that you get accurate results. And then vital signs are important in recognizing deterioration in the patient. So those are usually the first signs you kind of start to see, like, oh, their blood pressure's lowering, oh, their O2 sat's lowering, anything that could indicate something's not right. You can follow that trend and usually see, okay, this patient is starting to deteriorate, they're getting worse, we need to do something. Okay, and then this is just a little picture just to kind of help you remember that, some people's normal for them would be considered abnormal for somebody else. So, and we'll talk about some of these variations, but some people's blood pressure just runs lower, and that's normal for them. Sometimes their heart rate's a little bit lower. So some people's normal is a little different, and it may be outside of our quote-unquote normal ranges that we learn But that's why it's so important to get a baseline to know if it's normal for the patient or if it's something that we need to look further into. Okay, so the first vital sign we're going to talk about is blood pressure. So if you think of blood pressure, it is the blood pressure on the vessel wall. You can see your artery here. So it's the measurement of the force of the circulating blood on the blood vessel walls. It's measured in millimeters of mercury. So you'll see this little, abbreviation out by your blood pressure. That's how it's measured. And then it's expressed as a systolic pressure over a diastolic pressure. And you'll see it looks like a fraction. I'm sure y'all have seen blood pressures being taken before, seen your own blood pressure, so you kind of know what I'm talking about there. So just think about it's the pressure that's being exerted on the vessel walls. Okay, so blood pressure, like I just stated, is the systolic over diastolic. So as you can see in this picture, you have your systolic blood pressure. That is our top number. So that is when the heart is contracting. So you can see that that is when the heart is pushing blood out. So it's pushing the oxygenated blood down to the aorta or to the rest of the body. And then here, the deoxygenated blood is being pushed through the pulmonary artery into the lungs to be oxygenated. Then they'll come back through and then be pushed out to the rest of the body. But ultimately, you just need to know that systole, that's when the heart is contracting. So that is your top number. And then, so that's the maximum pressure exerted on the vessel wall during systole. And then diastolic, that's when the heart is relaxed. So our ventricles are relaxed and they're filling up with blood. That is the minimum amount of pressure exerted during diastole. So when the heart is relaxed. So your diastolic should be lower than your systolic. Okay, and so how we figure out what blood pressure is this little formula here, which this is just important to know to understand blood pressure and what affects it. So CO stands for cardiac output. So this is the output of blood coming from your heart. So the volume of blood pumped out of the heart per minute, that's your cardiac output. And then times your SVR. So SVR stands for systemic vascular resistance. So you multiply these and you get your blood pressure. So your SVR, that is the resistance that the blood has to overcome. So your heart is pushing out your blood. And then it has to overcome a certain amount of resistance. So that's what your SVR is. So this is just something to kind of have in your mind to understand what affects blood pressure. There are some videos, I think I assigned them on the course point, but if not, go through and look for the videos. They talk about blood pressure, and it kind of gives you a good visual to kind of help you understand what we're talking about here. Okay, so cardiac output, so the volume of blood pumped out of the heart per minute, like we said. Now this is determined by heart rate, contractility, so contractility of the heart is a muscle, so as it contracts, it's pushing out the blood. If it is not contracting appropriately, you're not going to be able to push as much blood out. Blood volume, so the amount of blood you have in your vasculature. So this could, maybe you're bleeding, maybe you're dehydrated, whatever it might be, your blood volume is decreased. And then also your venous return. So your blood that's already gone through the capillaries, oxygenated the tissues, it's coming back to the heart. That's your venous return. So that's your deoxygenated blood. So if there's an increase in cardiac output, then our blood pressure is going to increase. So if we have more blood coming out of our heart, more volume coming out to our arteries, then our blood pressure is going to go up. If we have a decrease in cardiac output, so we don't have a bunch of volume to pump out, then our blood pressure is going to decrease because we're not going to have much of that pressure pushing on the arteries because there's not much volume there. Okay? And then the systemic vascular resistance. So, like we discussed, it's the resistance that the blood has to overcome to pass through the arteries. So it's determined by constriction, so the constriction of the blood vessels. So that means they're smaller, you can have constriction, and then you can have dilation. Some things that affect this, constriction would be if a person is cold. Their blood vessels are going to constrict to try and hold the heat in. And then if someone is hot, their vessels will usually dilate because they're trying to get rid of that heat. So if your veins are more constricted, then you're going to have a higher blood pressure, more pressure on that wall. And then dilation is you're going to have less because the vessel is going to essentially, there's going to be more space in that vessel. And then the diameter of the arteries, this can be affected by peripheral vascular disease, when plaque can be built up due to different, chronic illnesses. This can lead to high blood pressure. So like diabetes can cause hardening of the arteries, or atherosclerosis. High blood pressure over time can lead to more narrowing of arteries. So this is just something to keep in mind, different things that are going to affect the blood pressure. So if our resistance increases, then our blood pressure increases. And then if our SVR decreases, our blood pressure decreases. Okay, so some other things that affect blood pressure. So it's a direct reflection of our cardiac output, blood volume, blood viscosity, so the thickness of the blood, vascular elasticity, we talked about this, the narrowing of the arteries or if they're constricted or dilated, and the degree of the peripheral vascular resistance. So there are intrinsic factors or non-modifiable factors, and then extrinsic factors or modifiable factors that puts someone at risk to develop high blood pressure or hypertension. So, for example, age is something that affects blood pressure. So, blood pressure gradually increases through childhood, reaching adult levels during adolescence, and then it tends to increase slightly throughout adulthood until older adulthood, when it decreases slightly. So there's age considerations. So the extrinsic factors are external factors that a client can control to some extent. So this will include weight, use of stimulants such as caffeine or nicotine, certain medications, sodium intake, stress, and activity level. Anxiety and fear has a great impact on blood pressure. It can cause their blood pressure to be elevated. Also, something to take note of is some patients have quote-unquote white coat syndrome. So if they come to a clinic and they get their blood pressure and it's elevated, it's important to consider that it may just be because they're nervous. So, taking that into consideration along with other factors, you may be able to determine if this is something that, is a chronic thing or if it's just because they are having anxiety. And then, of course, the patient's overall health status is going to affect their blood pressure. For instance, pain and fever can increase blood pressure. whereas hypoglycemia or low blood glucose level and heart failure can cause a decrease in blood pressure. So as a nurse, you have to use your clinical judgment, consider these factors when assessing and interpreting the significance of a client's blood pressure. Also, in your ebook, look at box 26.5. It kind of has more detail on some of the different factors that affect blood pressure. Okay, so again, intrinsic factors, non-modifiable. So these are things that a person has no control over. So age, ethnicity, African Americans are more likely to develop high blood pressure. Genetics, if your parents, maybe your dad had high blood pressure, you may be more likely to develop high blood pressure as well. Any natural hormonal variations, and then biological sex, so male or female, men are more likely to have hypertension as well. Extrinsic factors are modifiable, so these are things that someone can change, modify in order to help decrease their risk for high blood pressure or help lower their blood pressure if they've already had issues with hypertension. So weight, most people know that this has a negative impact on a person's health status, but it also causes the heart to work harder, and therefore their blood pressure increases. Use of stimulants, as we talked about earlier, so nicotine, caffeine, any kind of illicit drugs that are stimulants. Sodium intake, so the diet can be modified. Stress, activity level, so usually if someone is more active, their blood pressure is going to be lower. And then anxiety, fear, we talked about white coat syndrome, overall health status, and oral contraceptives. We talked about some hormonal changes that can have a big effect on blood pressure. So oral contraceptives can also cause an increase in blood pressure. So it's important to watch for that. Okay, so hypertension or high blood pressure, it is blood pressure above the expected normal range. So if someone just has one high blood pressure reading, this doesn't necessarily mean they have hypertension. We've kind of touched on this with the white coat syndrome. If someone's in pain, they have anxiety, etc. But what someone would do to be diagnosed with hypertension is they would have to trend their blood pressure and then report back to their primary care provider and then look at that trend and see if it's been elevated consistently. So normal for a healthy adult is less than 120/80. Hypertension puts people at risk for major health problems. They can have a stroke, they can have a heart attack, they can have an abdominal aortic aneurysm. Those are just some things that hypertension is a precursor to. It's known as a silent killer because a lot of times it doesn't have symptoms until it's pretty far along. And the reason why hypertension is so damaging to the body is that it's that high pressure that's pushing on the arteries and it's causing little micro tears. And when it does that, it causes plaque and platelets to build up, and then that causes the narrowing of the arteries. And then these plaques and things can break off and lead to heart attack or stroke. So this is why it's really important, to educate your patients on keeping their blood pressure under control if they do have hypertension. Okay, this is just kind of the classifications of hypertension. You don't have to know this for this class. It's just so that you can look at, obviously you need to know what the normal is, so less than 120/80. So elevated blood pressure would be considered 120 to 129, and then still diastolic less than 80. High blood pressure, hypertension stage 1 is going to be 130 to 139 over 80 to 89. Or, so you can have either or. Your diastolic can be elevated to 80 to 89, or your systolic can be 130 to 139. That would be the first stage of hypertension. And then hypertension stage 2 would be 140 or higher on your systolic, or 90 or higher on your diastolic. And then hypertensive crisis, you need to go contact your provider immediately, probably go to the ER. So systolic higher than 180 and or higher than 120 for your diastolic. So this is an emergency, and you need to get that under control because it can lead to stroke. Okay, and then we have hypotension or low blood pressure. So hypertension is high blood pressure, hypotension is low blood pressure. So this is a blood pressure that's below the normal reference range for a patient's baseline. If you don't have baseline data, then the systolic pressure less than 90, systolic or diastolic pressure less than 60 is typically considered hypotension for an adult. So some signs and symptoms of hypotension would be dizziness, headache, fainting. So remember, this is a low blood pressure. So for whatever reason, your body is not getting perfused adequately because of this low blood pressure. So you're not getting adequate blood and nutrients to your brain, different organs, so it'll cause dizziness, headache, fainting, pale skin, sweating and fever, and have an irregular heart rate because your body's trying to keep up. Have diarrhea, vomiting, shortness and shallowness of breath. It can cause seizures as well. So it can fluid depletion, so decreased volume. So that would be like our cardiac output is something is affecting that. So maybe the patient's bleeding, maybe they're super dehydrated. This would cause some hypotension, heart failure. The heart's not pumping appropriately, so it's not able to get the blood out to the tissues like it should. And then vasodilation, talked about the vessels dilating or becoming bigger, leading to low blood pressure as well. Okay, so now we're going to talk about measuring the blood pressure. So these are the things you will need. So you need a stethoscope, a blood pressure cuff. You got to make sure it's the right size. Sphygmomanometer, and that we'll discuss what that is. And then gloves if indicated. So this would only be if you're at risk for touching blood or bodily fluids. The patient's dry, everything, is pretty much normal. You don't have to use gloves, just use hand sanitizer before. So the stethoscope is used to auscultate or listen to the sounds of the blood flow through the arteries. We have to have an appropriately sized cuff. So as we discussed earlier, if our cuff is not the right size, it can cause an inaccurate reading. So the cuff width should be 40% of the circumference of the arm. And then the bladder should be 80% of the circumference of the arm. So you have the width, which is the short part, and the length, which is the long part. And we can kind of discuss this when we have class. It's easier just to show you. And of course, you'll be doing this in lab as well. So if the cuff is too large, then the blood pressure can be falsely low. If the cuff is too small, the blood pressure can be falsely high. So we need to make sure that our patients have an appropriately sized cuff. And then the sphygmomanometer, this is the dial, the calibrated dial that indicates the amount of pressure within the bladder of the cuff, which is measured in millimeters of mercury. Okay. So, first things first, we're going to check for any contraindications. So, some contraindications for blood pressure would be if a patient has had a mastectomy on either or both sides. So you want to ask, so maybe a patient has had a mastectomy on the left side. So when they do that, they take out the lymph nodes as well, usually. So when you put a blood pressure cuff on a patient's arm and squeeze it up, it could cause swelling and they're not able to drain that through that lymph node. So if a patient has had a mastectomy, one side or both, it's going to be contraindicated. If it's just one side, it'll be contraindicated on that left side or whatever side it is, so then you can take the blood pressure on the other side. Another thing is going to be a dialysis fistula. Y'all will learn about those. You'll probably see some of them in clinical. If a patient has that, you do not take a blood pressure on that arm. So it's important to ask patients if there's any reason why you should not be able to take a blood pressure on a specific arm. And usually they know to tell you. Okay, and then next we're going to position the client. So if the patient is in bed, help them to just kind of sit up with their back supported. Their feet should be flat on the floor. If their legs are crossed, you're going to ask them to uncross them because this can cause the blood pressure to read higher than falsely high. And then the client's arm should remain flexed at the elbow and supported at the level of the heart. So if the arm is above heart level, then this can cause a falsely low reading. If the heart is below heart level, this can cause a falsely high reading. So if the patient's in the bed, you don't have to have them dangle their feet if they can't do that. But if they're sitting up, they need to have their feet flat on the floor, legs uncrossed. If they're in the bed, just sit them up a little bit. Make sure their back is supported. Maybe prop their arm up on a pillow so that it's at the level of the heart. And then just make sure their legs are uncrossed. Okay. And then next, we're just going to expose their arm, measure the cuff, make sure it's the appropriate size. And then we are going to locate the brachial artery. So, as you can see, your brachial artery is right here. It is usually a little bit more medial or closer to the core of your body. You can practice on yourself, see if you can feel it. It is a little bit deeper, so you may have to press a little bit deeper in order to find it. But this is what your blood pressure cuff should be lined up with. Okay, so once you've found that, you can wrap your cuff snugly around the upper arm with the artery indicator. So you can look at your cuffs and you can see it'll usually have a little mark where it says artery and it'll indicate if it's on the left or right arm. So you know which one to line it up with. And then you're going to place your stethoscope over the brachial artery. So now you've got everything in place to take the patient's blood pressure. Okay, so then we are going to inflate the cuff. So there's a little bulb that's connected to this big sphygmomanometer. And this is what's used to inflate the cuff. There's a little dial on there too that you have to make sure is turned to the right, so righty-tighty, in order to fill it up. And then you will loosen that dial as you release the air. Again, this will make more sense when you're actually doing it, so don't stress too much about that right now. So you're going to inflate the cuff. You should inflate the cuff to approximately 30 millimeters of mercury above the expected systolic pressure value. So we're going to discuss if we don't have a baseline systolic, what to do. But if your patient can tell you, okay, my systolic is usually 120. So I'm going to fill my cup my cuff up to 150 millimeters of mercury. So that way I don't risk not getting an accurate blood pressure, maybe if it is more elevated than usual. Okay, so then we're going to open, once we filled it up, we're going to open the valve slowly. So this is what you turn all the way to the right to fill it up with. I usually make sure I've got it loosened just a little bit so it's easier for me to release that air, and you want to release it slowly. So you can make sure you tell when you hear the sounds. Okay, so you're going to loosely release that. You're going to try to do it at a rate of 2 to 3 millimeters of mercury per second, so pretty slow. So your first sound that you hear, because once you fill it up, you're not going to hear, you shouldn't hear anything because it's going to obliterate the pulse. The first sound that you hear is your systolic blood pressure. So wherever that needle is, whatever number it's on, the first time you hear a sound, that is your systolic. So identify the gauge value in millimeters of mercury when the first faint thumping sound is heard. So that's your systolic value. And then you're going to keep listening. And then you're going to identify the gauge value in millimeters of mercury when the sound disappears completely. So that is going to be your diastolic blood pressure. There is a good video on ATI for you to watch. They do this, and so you can watch and see how it's done. It'll probably make a little bit more sense. But just make sure that you're slowly releasing that air the whole time. Okay, and then this is another video on ATI that I will let y'all watch. The Karate cough sounds, that is the sound that you hear when you're taking a manual blood pressure. So once you're able to get into ATI, I would encourage you to look at this, and it'll kind of help simulate what it's going to be like when you're taking a blood pressure. Okay, and again, this just shows the proper positioning of someone who is, you're getting their blood pressure. So if they're in the bed, you've got them set up, legs uncrossed, arm at the level of the heart. And then if they're seated, you want to make sure they have a back rest and that their legs are uncrossed and feet are flat on the floor. Okay, so if our patient, for whatever reason, we don't have baseline data for what their normal blood pressure usually is, we're going to estimate their systolic. So for this, you'll see in the book, I think they use the radial pulse for this, but in lab, I think they use the brachial pulse. But for lab and for this class, we are going to talk about it using the radial pulse. So the radial pulse is on your wrist. I'm sure most of y'all know where the radial pulse is. It's easier to feel for usually than the brachial. Okay, so what you're going to do, you're going to do everything like you would normally do to, get set up to take a blood pressure. But you're not going to have to use a stethoscope for this one. You're just going off of the radial pulse. You're going to be palpating it or feeling it. So you're going to inflate the cuff until the radial pulse is obliterated so you can't feel it anymore. At that point, you're going to note the number on the gauge in which you could no longer feel the pulse. And then this would be your estimated systolic. So then once you get that, you can wait about 30 seconds to a minute and then take their actual blood pressure, and you're going to inflate the cuff 30 millimeters of mercury above the estimated systolic. Okay, so next we're going to talk about pulse. So this is defined as the rhythmic throbbing or beating caused by the expansion and contraction of the arteries in response to the ejection of blood from the left ventricle. So your left ventricle, again, has the oxygenated blood. It's being pushed out into your arteries. So that pulsation that you can palpate, that is the expansion and contraction of the arteries. The expected reference range is 60 to 100 beats per minute. So that's a normal range of which your heart should be beating. So here this just shows the electrical system of the heart. You don't have to memorize all this right now, but just know that this is your SA node right here. So that is your intrinsic pacemaker. So that's your natural pacemaker of your heart. And then it conducts to the rest of the heart to kind of let it know when it needs to contract. So the SA node produces electrical impulses, and it travels to the AV node, and then to near the ventricles of the heart. The electrical impulses causes the heart muscle to contract, thereby setting the pulse rate or heart rate. Okay, so what affects pulse? So body position, kind of the same as the blood pressure that we talked about. Sometimes different body positions can affect blood pressure. Same with pulse. Age is another factor. Activity level. If somebody is extremely active, like an athlete who exercises or runs every day, a lot of times their heart rate will be lower, like maybe in the 40s or 50s, and that's normal for them. Heart conditions can affect this, whether it's some in electrical, so like maybe atrial fibrillation, some other arrhythmia, it will affect the pulse. And then body temperature. As your body temperature rises, your pulse will rise. As your body temperature lowers, your pulse will lower. Certain medications can lower the pulse or increase. And then caffeine and nicotine again with your stimulants, that's going to cause your pulse to be increased. Okay, so for grading pulses, you need to know this. This is a part of your assessment data along with your vital signs. So as you can see here, we've got our radial pulse, brachial, carotid. You're not usually going to feel your temporal artery. We'll talk about your apical pulse, popliteal artery. You have your pedal pulses in your posterior tibial. So you'll feel these usually with your head to toe assessment, and then this is how they will be documented. So +2 is normal. 0 is they don't have pulse, or is no palpable pulse at least. 1 is pulse that is weak or diminished. +3 is a pulse that is increased or strong. And then 4 is a pulse that is bounding. So it's just important to remember this. You'll get used to feeling different grades of pulses once you get to clinical and start doing it in practicum. But just make sure you know what each grade means. Okay, so tachycardia means that your heart is beating faster than 100 beats per minute. And then some clients will have symptoms with this, some won't. Some report a racing feeling in their chest because their heart is beating so fast. So things that could induce tachycardia or fast heart rate would be exercise. So when someone's exercising, your heart rate is going to increase. Fever or heat exposure, medications, changing positions from lying to sitting or sitting to standing, acute pain will cause an increase. Hyperthyroidism, y'all will learn more about, the function of the thyroid, but you can remember it for now as the thyroid, you can speed things up. So if your thyroid is hyperactive, it's going to cause an increase in heart rate. Anemia or hypoxemia. So anemia is low blood count, and then hypoxemia is a low amount of oxygen in the blood. Stress, anxiety, fear. So hypovolemia. So that means that we have low volume in our vessels. That can cause tachycardia because your heart's trying to keep up and make up for the lack of volume that you have. Heart failure, hemorrhage, and then dehydration goes hand in hand with the hypovolemia. So if you have a patient who has been otherwise normal, then their heart rate jumps up, they're not in pain, you may want to assess their fluid status and see if maybe they need some fluids, because this can be a good indicator of a patient being dehydrated. Okay, bradycardia, so this is pulse less than 60 beats per minute. A lot of times there's no symptoms again with this. If a person is physically fit, it may be normal for them to be bradycardic. But if a person is bradycardic, they can have dizziness, fatigue, shortness of breath, chest pain, and confusion. So these are kind of similar to the hypotension, the low blood pressure signs and symptoms, because essentially the heart's beating too slow. So it's the so you have decreased cardiac output because it's not able to pump out the blood appropriately. Hypothermia, this can lower your heart rate. So when a person is cold, it usually slows things down, so it slows down your heart rate. Certain medications can cause bradycardia, digoxin, beta blockers, calcium channel blockers. Usually a patient is on this because they have problems with their heart rate being elevated or their blood pressure being elevated. Changing positions from standing to lying down. Chronic severe pain. So if they have chronic pain, it can actually cause low heart rate, bradycardia. Hypothyroidism. So our thyroid's not working like it should, so our body processes are slowed down. And then relaxation. Okay, so apical pulse. So this is the heart rate that is heard or felt at the apex of the heart. So you will use your stethoscope for this. You can palpate it, but ideally to measure the apical pulse, you are listening to it. So it's located medially to the midclavicular line at the fifth intercostal space. We'll be looking at a picture of that. If the pulse rate is irregular or outside of the expected reference range, this is when the nurse would also take the apical pulse for 1 minute. So if you're feeling a radial pulse and it just does not seem regular, something's not right, then you would listen to the apical pulse for a full minute. This will confirm if the pulse is abnormal, and if it is, you need to notify your provider. So if a person has an abnormal pulse, this would be considered an arrhythmia. So that would be an irregular rhythm. Some arrhythmias are not harmful, and they can be unnoticed. Other can have physical manifestations such as shortness of breath, dizziness. So if you feel something off, you would want to auscultate the apical pulse, and then the nurse can palpate and auscultate the apical pulse over the apex of the heart. In adults, adolescents, and children older than 7 years of age, the apical pulse is located at the fifth intercostal space on the left side of the client's chest at the midclavicular line. In children younger than 7 years, the apex of the heart is located at the fourth intercostal space to the left of the sternum. So just remember that if you are assessing a child less than 7 years, it's going to be at the fourth intercostal rather than the fifth. Okay, so landmarking for your apical pulse. So first you're going to find your suprasternal notch. You can see here. Down to the angle of Louis. This is kind of hard to feel, so practice on yourself. You'll go over this in lab again. But it's just kind of like a little ridge almost that's right here. Okay, so you're going to feel that, and then you're going to go over to your second intercostal space. So that angle of Louis should be in line with your second intercostal space. And then we're going to go over to the mid-clavicular line. So this is your clavicle, so middle of the clavicle. And then you're going to count, just count down from your second, third, fourth, fifth intercostal space, mid-clavicular line. This is where you should be listening. And then this shows the difference here. So infant or young child, less than 7, you're going to listen right here at the fourth intercostal. But for an adult, you're going to listen here at the fifth intercostal space. So if you are listening to an apical pulse, then you want to place the diaphragm of the stethoscope, that's the bigger part of the stethoscope, over the apex of the heart. So the apex of the heart, is right here. So this is your apex, okay? So you're going to listen over the apex of the heart, listen for 1 full minute. So something that can be confusing when you're listening is that the love-dove sound is 1 beat. So the systolic and the diastolic sound is 1 beat. So when you're palpating a pulse, radial, wherever, you'll just feel 1 pulse. But when you're listening, it's going to be a love-dove sound. So that is one pulse. So this is your S1, your S2. This is 1 beat. Okay. So next we're going to talk about body temperature. So this is the degree of heat of the human body. So normal in Celsius is 35.8 degrees to 37.5. In Fahrenheit, it's 96.4 to 99.5. Average is 37 degrees Celsius. In Fahrenheit, average is 98.6. So our body temperature is the measurement of the balance of heat produced by the body and heat lost to the environment. It's measured in degrees. A core temperature is the temperature of the deep tissues within the body, whereas a surface temperature is the temperature of the skin, fat, and subcutaneous tissue. So body temperature generally falls within a fairly narrow expected reference range. For most clients, an average temperature is, as we discussed, 37 degrees Celsius or 98.6 degrees Fahrenheit, with a slightly lower average expected in older adults. So your neurological system and your cardiovascular system work together to regulate the body temperature. So disease or trauma to the hypothalamus or the spinal cord will alter the temperature control. Those are part of the neurological system. But also maybe if we have decreased cardiac output, we could have a lower body temperature as well. Also to note, these ranges here are what is consistent with what you have to know for your practicum, your lab, because we have a clinical site agreement with our hospitals around here, and this is what they want you to know. But in course point, your normal range is 96.8 to 100.4 degrees Fahrenheit. So just be aware of that discrepancy there. But what's on this PowerPoint, I have a graph or a table at the very end that shows exactly what you're going to have to know for your lab, and I'll make sure that's consistent with my tests as well. So fever or hyperthermia, so that's going to be an elevated temperature. So it's an increase in body temperature above the expected reference range. So again, the 99.5 is what you need to know. This is what is listed in your book. Commonly caused by infection. So a lot of times when someone has a fever, we think they've got an infection somewhere. So symptoms may include a flushed face or red face, diaphoresis or sweating, skin that feels hot, tachycardia, and increased respiratory rate. So usually our body's working harder, we're going to have increased heart rate and increased respiratory rate. So what are some things as a nurse that we can do to help a client who has fever? So we can encourage them to sip on cool fluids if they can. They're not NPO. Remove excess clothing. A lot of times the patient is going to be cold, so they may want a bunch of blankets on them, but we need to educate them that in order to get their temperature down, we need to remove some of the blankets. Or maybe they have big fuzzy socks on and a coat, whatever it might be. And then we're going to give medications as ordered. So our antipyretics, those are to reduce or prevent fever. So that would be like Tylenol, the generic name is acetaminophen for that. That is very common to be ordered PRN or as needed for patients in the hospital for temperature. And then, of course, if they do have an infection, you want to make sure you give the antibiotics or antivirals as that is ordered. And then, of course, you can place the client in a cooler environment, maybe turn their thermostat down, or give them a fan, something like that, just to help lower their body temperature. And a lot of times you'll do a combination of these, especially if they have a very high temperature. You can also give a tepid bath to help cool their body down. Okay, so hypothermia. So that is a low body temperature, so decrease in the core body temperature due to extended exposure to cold or the inability of the body to produce heat. So as we discussed earlier, it can be a neurological issue if there's some kind of trauma or damage, to the hypothalamus or the spinal cord. The patient's body may just not be able to regulate their temperature. So early signs of this would be shivering, decreased motor skills, so hypothermia, kind of think everything's slowed down, impaired peripheral perfusion, so perfusion by the arteries. So this is usually because, as we discussed, when a patient is cold, their blood vessels are going to constrict to try and hold that heat in. So that's going to decrease our peripheral perfusion because it's trying to hold all the heat into the core body. Our peripheral, so our arms, legs, especially fingers and toes, are not going to be perfused appropriately. So late signs of this, it's gone on for some time now, would be confusion. Patient may not be able to concentrate, and even loss of consciousness. So severe hypothermia is a medical emergency. It leads to loss of deep tendon reflexes, can lead to a coma, and high risk for cardiac arrest. So if a patient has a body temperature slightly below the expected reference range, a warming mat or blanket, may be all that they need to restore their body temperature. So again, you have to kind of, think about what interventions you want to implement based on how severe a patient, how severe their hypothermia is or hyperthermia is. That would kind of help you decide what interventions are most appropriate for that patient. Okay, So I've talked about core temperature. So we're going to discuss what that is versus surface temperatures. So your core temperature sites, so this is where you can take your temperature, is the rectum, tympanic membrane, so that's the ear, temporal artery, so that's the temporal artery on the forehead, pulmonary artery. You will not be doing this as if someone has like a central venous line, pulmonary artery catheter that has like a temperature, a way to read the temperature off of it. Esophagus, you won't usually see this unless somebody is intubated in the ICU. And urinary bladder. So a lot of the Foley catheters now have a way to measure temperature on them. So those would all be considered core temperature sites. Don't stress about the pulmonary artery and esophagus. You won't probably see either of those used until you get to ICU. Surface temperature sites are going to be your skin, your mouth, and your axilla, or your armpit. So those are going to be your surface temperatures. So with your core temperatures, those are usually going to be a little bit higher, and sometimes maybe a little bit more accurate because they're not affected as quickly by the environment as the surface temperatures are. Okay, so our different routes we're going to talk about are the oral, tympanic membrane, temporal, axillary, and rectal. So as you can see here, this is going to be your oral thermometer. This is going to be your temporal. So this glides across the forehead. This is going to be your tympanic. So it goes in your ear. And this is your rectal. Anything that has red on it, any thermometer that has red on it, is a rectal thermometer. And it should not be used anywhere else but in the rectum. Okay, so oral, this is probably the most commonly used one. It's easily accessible, doesn't really matter what position the client is in, and it accurately measures body surface temperature. Some disadvantages are risk exposure to body fluids, just because it's the mouth, but if you feel that you're at risk for coming in contact with that, just put some gloves on. It will be considered inaccurate if the client ate, drank, or smoked in the previous 30 minutes. So this is something that you always want to ask when you're taking an oral temperature, as if the patient has ate, drank, or smoked in the past 30 minutes. If they have, you either need to go a different route or wait 30 minutes and then take the temperature. It's not good for newborns. Obviously, they're not going to be able to follow directions and keep their mouth shut. So just don't use in newborns, infants, young children, due to safety concerns as well. So this needs to go under the tongue into that buccal pocket, and then have the patient close their lips around the probe. Okay? And then tympanic, so this goes in the ear. Again, this is easily accessible. Rapid result available in less than 5 seconds. That's good when you don't have much time as a nurse. Accurately measures core body temperature. So this is something that's different than the oral. And then the result is not altered by the environmental temperature. So this may be a more accurate reading. So some disadvantages to this, if a patient has cerumen, so that would be like earwax, if they have a bunch of earwax, or they have an ear infection, it's not going to be accurate. Again, it's typical to obtain with newborns, infants, any child younger than 3. And this is kind of due to like a anatomy issue, which I'll discuss in the next slide. And then it also requires removal of hearing aids. So that's just another disadvantage of that. Okay, So how to appropriately do this for an adult, you're going to pull the pinna up and back. This is your pinna right here. So for adults, you pull it up and back. And for children less than 3, you're going to pull the pinna down and back. And that's just because the different angle of that canal. So just remember that children less than 3, you're going to pull the pinna down and back. And for adults, you're going to pull it up and back. Okay, so temporal. So think of this as your, where your temple is. That's where your temporal artery is. So advantages, it's easily accessible, rapid result, no risk of injury. You're just kind of gliding it on the patient's forehead. And it's really accurate for all age groups, infant, adult. It reflects rapid changes in the body's core temperature. So again, this one is considered a core temperature. So disadvantages, it's affected, the reading is affected by the moisture on the skin, such as sweat. So if a patient's real sweaty, this is not going to be a good option for them. Also, if the patient has had a head covering or hair, maybe they have bangs, or they've had something on their forehead, you're not going to have an accurate reading. So to do this, you place the probe on the center of the forehead above the eyebrows, and then you're going to press the button here. And then you're going to slide the probe across the client's forehead toward the hairline or the temple while the button remains depressed. Then you're going to lift the probe while the button remains depressed and place a probe on the skin behind the client's ear. And then release the button, and it'll give you the reading. So this one takes a little bit of practice, but once you see it done, it's really easy. But start with the middle of the forehead, go to the temple or the hairline, pick it up, keep the button compressed, and then place the probe on the skin behind the ear, and then release the button. And this usually has a higher reading than an oral temperature, about 1 degree Fahrenheit, and then about 2 degrees Fahrenheit higher than axillary temperatures. Okay, so axillary, so this is under the armpit. So it's accurate for all age groups. Really no risk of injury using this method. Disadvantages is it takes more time to obtain a reading than with other methods. So sometimes you'll be sitting there for a little bit waiting for it to read. So this temperature is not a core temperature, so it does not reflect rapid changes in that core temperature. And it may be easily altered by environmental temperature. So this is something to take into account as well. So it should be, the end of the probe should be placed in the center of the axilla, and then make sure that the client's arm is down close by their side. So axillary temperatures are usually 0.5 degrees Celsius or 0.9 degrees Fahrenheit lower than oral or tympanic temperatures. So if you're taking an axillary temperature, kind of a good rule of thumb is just to add a degree to that, and that's probably their most accurate temperature. Okay, and then rectal. So it is a very reliable test. There is a risk for injury in the rectal mucosa. Result can be altered due to presence of stool. It's generally unpleasant, as I'm sure you can imagine. So this is usually not our first, method of getting a temperature. But if we've tried a bunch of other methods, they're maybe reading extremely low, extremely high. We need to make sure it's accurate. Then we might move to a rectal temperature for adults. Shouldn't be used in clients who have diarrhea, hemorrhoids, rectal surgery, or coagulation disorders. Coagulation disorders are like clotting disorders, so we don't want to cause them to bleed. Again, usually there's a red indicator on a rectal thermometer. Oral or axillary thermometers can be used. This is not recommended. There are probe covers, but still, just best to not mix those. And then rectal temperatures, they're usually the highest temperature of all the sites, and they're about 0.5 degrees Celsius or 0.9 degrees Fahrenheit higher than oral and tympanic temperatures. So now we're going to talk about respiratory rate. So respirations consist of inspiration and expiration. So inhaling, exhaling. Inspiration is the intake of air by the lungs in order to oxygenate the body tissues and support cellular function. So inhaling here, you can see the person is breathing in, and so their lungs are expanding. Right here's your diaphragm, so it's going down, and then your chest is expanding out in order to fill the lungs. And then as you exhale, you're expelling carbon dioxide from the lungs, getting rid of that waste. And at this moment, your diaphragm is going to go up, and then your chest is going to come back in, and you're going to exhale that air out. The expected reference range for this is 12 to 20 breaths per minute. So for counting respiratory rate, we're going to make sure the client is relaxed and at rest. Otherwise, it may give inaccurate results. So you're going to count the number of sets of inspirations and expirations to determine breaths per minute. So you can observe or auscultate breath sounds for 30 seconds. Do not tell the client you are counting their breaths. So typically what we teach in lab is to, while you're counting the patient's pulse rate, so you're feeling their apical pulse or whatever pulse, usually it's going to be apical. So for the first 30 seconds, you're going to count their pulse, excuse me, and for 30 seconds. And then you'll multiply that by 2 to get your beats per minute. Then for your respiratory rate, you're going to listen for that other 30 seconds and count how many times they're breathing in those 30 seconds, and then multiply that by 2. So that's an easy way to get both of those done at the same time. So you can just tell your patient that you're feeling their pulse. And a little trick is just having them place their arm over their chest, as the nurse is doing here. And that's a little bit easier to see their chest rise and fall. So, and again, you don't want to tell your client that you are counting their breaths, because they may subconsciously alter their rate of breathing. So just don't tell them that you're measuring that. Okay, so tachypnea, so this is increased respiratory rate, so above expected reference range, usually greater than 20 breaths per minute. Some causes are going to be physical activity. You're going to breathe faster when you're, being active. Anxiety, and pain. So anxiety and pain, we know, increase a lot of our vital signs. So we'll increase our respirations as well, or can. And then any health conditions, like maybe some respiratory disorders such as asthma, can cause this as well. So common symptoms of this are dizziness and tingling in the hands. If you ever, maybe been anxious, or for whatever reason you're hyperventilating, you may have felt dizzy or felt tingling in your fingers, and that's because you're probably breathing too fast. Okay, and then bradypnea is decreased respiratory rate below the expected reference range, so less than 12. health conditions can cause this. Medications such as opioids or sedatives, they'll decrease the respiratory drive. A lot of times Ativan is given in the hospital, and it is known to cause a significant decrease in respirations. So you want to make sure to monitor that anytime you're given that, or anything that's going to sedate the patient can decrease their respiratory rate. Symptoms of this would be dizziness, fatigue, weakness, confusion, and impaired coordination. So since they're breathing slower, they're not getting oxygen to their body adequately. So that's what leads to these symptoms. Okay, and then lastly, we're going to talk about oxygen saturation. So this is O2 sat, not O2 stat. You'll probably hear that some, but it's oxygen saturation, so S-A-T, not S-T-A-T. So this is the estimated amount of oxygen bound to the hemoglobin. So the hemoglobin are your blood cells, that carry oxygen to the body. It's expressed as a percentage. It is a direct reflection of the client's respiratory status. It's measured using a pulse oximeter. We will talk about that. And then the SpO2, you may see that in a chart. That is what pops up when you're getting an oxygen saturation. So that's the same thing. SpO2 is the same as oxygen saturation. So that's the amount of oxygen that's being transported to the body tissues. Expected reference range is 94% to 100%. Again, some people's normal will be a little bit different than this. If someone has COPD or chronic obstructive pulmonary disorder disease, it will usually their oxygen saturation will run lower. We'll talk about this more in the oxygenation lecture, but it's important not to increase their oxygen too much. So you want to know what normal is. Most of the time it's going to be 94 to 100%, but if someone does have COPD, that's going to be, something they may run 88%, and that's normal for them, and we're okay with that. Otherwise, it needs to be higher than that. Okay. So, how to measure this is we use pulse oximetry. You've probably had this done before, but it's just a little, it's kind of like a little clamp that they place on your finger, and it measures your O2 saturation. So, of course, when you're selecting a site, usually it's going to be a finger. You want to make sure that they have adequate perfusion. So if someone's extremely cold or something like that, their fingers don't have good perfusion for whatever reason, you're not going to get an accurate reading on that pulse ox. So other sites that can be used are the ear, nose, and big toe. So finger is most common, but if for whatever reason you can't use a finger, you can use the ear, nose, or a big toe. So you want to make sure the site is clean and dry and intact. So dark nail polish can actually cause an inaccurate reading. So sometimes that nail polish may have to be taken off in order to get a reading. You're going to just place the probe on the finger, and then you're going to instruct the client to keep still. Usually it takes a few seconds for it to kind of regulate and read. So just have them keep still, otherwise it may not be accurate. And then just wait until the pulse rate and O2 sat are consistent. So it will also read a pulse rate on this as well. Okay. So lastly, Dr. Camden sent me this. This is what y'all need to know for lab. For me, you are going to need to know the adult values here. They are all consistent with what we talked about. The temperatures are kind of what we had a little bit of variation with the book, but these are the temperatures that you need to know for your test. Everything else should be consistent, but this is also what you will have to know for lab, so just make sure that you know these. And that is all I have, so please come to class next week with any questions you have about vital signs. Send me an email. I'd be happy to help any way I can.